Welcome, everybody. Welcome to another episode, if you will, of Live from Cleveland Clinic. We're super excited to have all of you join us. These are exciting times. We've been able to take something that we've learned from COVID to be able to reach the masses and have an interactive discussion about what we hope is, something that in some places is being performed quite a bit, and in other places not a lot. So tonight we're going to talk a little bit more about lateral pelvic lymph nodes and rectal cancer, and really focusing on that multidisciplinary approach. And on behalf of my fellow activity director, Dr. David Rosen, we welcome you to Live at Cleveland Clinic. Next slide. So every time that Rita puts this slide together, it's exciting. And for some people, it's in the middle of the evening. Some people, it's tomorrow morning. But I can assure you that, 900 healthcare providers from over 90 countries, that's amazing that we could all come together and talk about this. I can only tell you, from those of you unlucky enough not to live here in beautiful Cleveland, Ohio, it's 75 degrees and sunny outside, and we wish you were here in person to join us. Next slide. First, just a giant thank you, if you will, to our corporate sponsors for your generosity in providing the educational grants for this entire 2024 series. We could not hold these CME offerings without our industry sponsors, and we're certainly most grateful for them. You can see Cook and Janssen Biotech, Medtronic, and Olympus Corporation of the Americas. Just a giant thank you for making this all happen. And again, thank you for your partnership and collaboration and vision to be able to do these Live from Cleveland Clinic. Next slide. So it's my pleasure to introduce our faculty. They will be coming on and having an interactive discussion. First, David Rosen, who is my fellow activity director. I'm going to turn it over to him shortly. He's our chief section of colorectal surgery on our west side at Fairview Hospital. David's been with us for the last several years, and excited to have him be not only leading this, but for those of you who want to join our other live series on Friday mornings, it's just a great thing that David puts on, and we can give you more information on that. Dr. Bala Magwala Asan is one of our radiation oncologists specializing in GI pathology. Within our Department of Radiation Oncology, our Imaging Institute, and Assistant Professor of Radiation Oncology at Cleveland Clinic Lerner. Dr. Jocelyn Canavan, who's also another radiation oncologist in the Department of Radiology, mostly located at our Mall Cancer Center at Fairview Hospital, and then also an Assistant Professor of Medicine at the Cleveland Clinic Lerner College of Medicine. Dr. Amar Gupta, who's a radiologist, abdominal imaging, and interventional radiologist within the Department of Radiation Oncology and the Imaging Institute, and assistant professor of radiology within Cleveland Clinic Lerner. Dr. Kosra Karamalu is a staff hematologist in medical oncology within our cancer center, and assistant professor of medicine within Cleveland Clinic Lerner. And Dr. AJ Keshenro, who is our newest addition to our team of colorectal surgeons here at the Cleveland Clinic out on the west side, but super excited to have AJ here. And last but not least, our new chair of colorectal surgery, that as of May 1st, I am no longer the chair, and just a giant congratulations and welcome to Dr. David Liska, who is the 5th chair of colorectal surgery since 1949. David, congratulations and welcome with that. I'm going to turn it over to my partner in crime, David Rosen. David, thank you.
Dr. Steele, thank you very much. Thanks everybody for joining us. Like Dr. Steele mentioned, is so excited for tonight's session. We've got a great lineup, and with that, we're going to get right into it. So we have time for some presentations. We're going to do that for about half the time, and then we're going to jump into some case presentations where I'm going to try to stump this audience and see what they would do in some real life scenarios that we've had as patients here at Cleveland Clinic. So first up, I'm going to introduce Dr. Amar Gupta, as Dr. Steele introduced him as a member of the abdominal imaging section of radiology at our Cleveland Clinic main campus. But Amar is more than that. He is, for what we know, these lateral pelvic lymph nodes, which have taken off in terms of how we manage these and the differences regionally throughout the world of how this is managed. Here in the Western world, the management is changing rapidly. And locally around Cleveland Clinic, these nodes are known as Gupta's nodes because no one can identify them like this man right there. So he's going to walk us through how we figure out, is that a positive lateral pelvic lymph node or not? So Amar, the floor is yours.
All right. Well, thank you for that kind introduction. Let me just share my slides here. Good evening, everyone, and I'm excited to be here. Today, I'll be talking about essentially how do we identify positive lateral nodes, specifically on rectal MRI. Let me advance here. So today we'll basically describe the anatomic distribution of lateral pelvic lymph nodes and talk about some of the MRI imaging features that we look for in order to identify abnormal lymph nodes. And so, as some general background, what we consider lateral pelvic lymph nodes include internal iliac, obturator, and external iliac lymph nodes. And these lymph nodes are specifically referred to that way because they're situated outside of the standard total mesorectal excision. And they're important because they are a site of local recurrence, even in the era of neoadjuvant treatment and total mesorectal excision. And when found in primary staging, lateral local recurrence will often occur within 5 years. So this slide represents several cross-sectional pelvic MRI images in which we've used color here to delineate some of the anatomic distribution of these lymph nodes. So in red are the external iliac lymph nodes that we see. These are situated anteriorly and along the external iliac artery and vein, and they are caudal to the common iliac bifurcation. What we refer to as pelvic sidewall nodes include the obturator and internal iliac nodes. The obturator compartment is in green and is located lateral to the internal iliac artery and caudal to when the internal iliac artery exits the pelvis. And in blue are the internal iliac lymph nodes, and that is essentially medial to the lateral border of the internal iliac. And so using this, we look to identify imaging characteristics that are associated with abnormal or metastatic lymph nodes. And really, we use several sequences, including T2 weighted imaging, diffusion, and enhancement. And so some of these imaging characteristics have been derived from something called the Dutch criteria, which we may talk about a little later, and include several things, including round shape, irregular borders, and heterogeneous signal intensity. Much of this is actually found on T2 weighted imaging and is correlated on subsequent sequences. Short axis guidelines essentially include these three main criteria. So short axis greater than or equal to 9 millimeters is considered abnormal regardless of morphologic criteria. When measuring 5 to 9 millimeters, at least 2 morphologic criteria are needed to qualify for a abnormal or metastatic node. And less than 5 millimeters, all 3 morphologic criteria are needed. And again, these criteria are what are included above here. I will say, practically speaking, less than 5 millimeters, it's very difficult to really include all of these criteria. And generally speaking, I will say that most often we are sort of falling into this 5 to 9 millimeter with a couple of criteria or greater than 9 millimeters. So let's look at some cases together. Here I've included 4 representative images of T2 weighted imaging and post-contrast enhancement of some abnormal right external iliac lymph nodes. So at one level here, we can see abnormal lymph nodes. Again, in the right external iliac distribution, we can see that the margins of these nodes are very irregular. They have a somewhat round shape and this very heterogeneous signal intensity on T2 weighted imaging. We can see enhancement of these nodes on post-contrast images. And then inferior to this area, we can see a representative image of a necrotic right external iliac node. And that's where we see this fluid attenuation within the central portion of this node. and we can see the enhancement around that area. Also, again, we use diffusion-weighted imaging, and here we see essentially increased diffusion signal corresponding to low signal on what's called an ADC map. And this is how we define essentially restricted diffusion, or diffusion that we associate with an abnormal or metastatic node. This is a coronal T2 projection of that same node, demonstrating central necrosis corresponding to the prior images. This is an example of a internal iliac node, which nicely demonstrates some of these features, and we can see very clearly. In this case, this has increased diffusion signal. This is a very classic image of a again, irregularly marginated, heterogeneous, somewhat round appearing lymph node. This is in the left internal iliac distribution, and this also has post-contrast enhancement. We do have some imaging tools that we use in somewhat of a problem-solving way. Essentially, these are images from a PET scan. All PET scans include a non-contrast CT, and this basically demonstrates this large right external iliac node in a patient with rectal cancer. Here we can see that there's increased hypermetabolic signal here, and in general, these modalities are not necessarily used to characterize the node, but are rather helpful in terms of problem solving. Characterization would typically occur again on the MRI, and that's where we use a lot of the morphologic criteria that we discussed. So why does all this matter? And this is something that we'll be discussing later on this evening. Essentially, lateral pelvic lymph nodes really play a major role in local recurrence, especially in low rectal cancer. And lateral recurrence can often be common and really impacts chemotherapeutic and surgical options. And so it's very important to be able to identify these ahead of time. So that's what I have for tonight, and I'm happy to take any questions.
Amazing. Thank you, Dr. Gupta. Yeah, any questions, pop them there in the chat, and we're gonna have we'll have a little bit of a discussion Q&A type session later. We can get to all those. That was a great overview, and I think we all completely understand how to identify lateral pelvic nodes on our own, or as they're known here as Gupta's nodes. So with that, so now that sort of sets the stage in terms of how to identify these lateral pelvic lymph nodes in our patients with rectal cancer, how we might identify nodes that we think are positive. The next step, of course, is what do we do about them? And so a big part of our management of locally advanced rectal cancer and patients with, that includes patients with positive lateral pelvic lymph nodes, is neoadjuvant therapy. And kind of the cornerstone, Dr. Karamlu, our medical oncologist, might argue with this, but the cornerstone of a big part of that is radiation oncology, is radiation therapy. Even though we know, Kazra, the chemo is more important. Don't let Asan try to tell you otherwise.
Chemo is always more important. Yeah.
That's right. So anyway, but we're going to have Dr. Asan Balagamwala is going to talk to us a little bit about radiation oncology considerations when it comes to these lateral pelvic lymph nodes. How do we treat them? Do we treat them any differently, et cetera, things like that. Asan is, the head of our lower GI radiation oncologist at Cleveland Clinic main campus, and he has told me before that he only became a radiation oncologist because he failed his surgical rotation. So it's not everyone's cut out for it, but we still love him. He's the best. And so, Asan, I'll give it over to you to walk us through this.
Well, thank you, Dave. I am truly a surgeon at heart, and so I always appreciate talking with my surgeons. So let me get started here. Perfect. So we'll talk about short course, long course radiation, boost radiation, and overall how do radiation oncologists think about this and how should we think about it. So objectives, we're going to learn about the role of radiotherapy in the management of lateral pelvic nodes, and as I said, understand the differences between different radiation modalities and when to use what, depending on the patient. And so the incidence of lateral pelvic nodes is about 11 to 22%, depending on the studies that you look at. And what's important is that patients that have lateral pelvic lymph nodes involved, they have a poorer overall survival as well as recurrence-free survival. And so their local recurrence in patients with lateral pelvic nodes can be as high as 44% compared to those that don't have lateral pelvic lymph nodes, and their recurrence is about 12%. And some of the risk factors associated with lateral pelvic lymph nodes are low rectal tumors, poorly differentiated adenocarcinomas, positive mesenteric lymph nodes, which are mesorectal or internal iliac, as well as lymphovascular space invasion. And so the reason why lateral pelvic lymph nodes are so relevant is that if you look closely at the AJCC 8th edition, which is the latest edition, the regional nodes for rectal cancer are defined as mesorectal, superior rectal, inferior mesenteric, internal iliac, and inferior rectal. And so external iliac nodes, obturator nodes, common iliac nodes are technically M1. And so those patients technically, per the AJCC, fall as stage 4 patients. And if you look at the survival, depending on the stage of the patient, so if they're node negative, they have a very good overall survival, and that survival decreases as the nodal burden increases. So mesorectal patients with mesorectal nodes have slightly lower survival, and when we get to external or the lateral pelvic lymph nodes, the survival is significantly lower. But it's important to compare that to patients that are stage 4 that we treat curatively or eligible for curative treatment. So these are patients with a single liver metastasis, for instance, and we would do definitive curative treatment, which would involve surgical resection, not only of the primary, but also of the liver. And turns out patients with external pelvic lymph node, with lateral pelvic lymph nodes, excuse me, actually have a better survival than even those patients as stage 4. And so hopefully the AJCC 9th edition will reflect that distinction between patients with lateral pelvic lymph nodes versus de novo stage 4. And Dr. Rosen will talk about the role of surgery for lateral pelvic lymph nodes, and I will discuss more about how or whether neoadjuvant radiation makes a difference in these patients who have clinically positive lateral pelvic lymph nodes. This was a study by Kim and colleagues looking at 900 patients who underwent TME with either neoadjuvant chemoradiation or adjuvant chemoradiation. And 2/3 of the patients received neoadjuvant chemoradiation. The local recurrence risk was about 7%, and the majority of those local recurrences were in the lateral compartment. And what they found was patients that had a 5 millimeter or less lymph node in the lateral compartment, they basically had no risk for recurrence. However, as the size increased, went to 5 to 10 millimeters, their risk increased, and it was significantly higher for local and local regional recurrence if it was more than 10 millimeters. And that actually translated to a survival difference as well for patients with 10 millimeter or greater lateral nodes had a significantly poorer survival compared to those that had nodes that were less than 10 millimeters in the lateral compartment. The MD Anderson group also looked at it. This was a smaller study from MD Anderson. In this study, patients underwent long course chemoradiation followed by TME and either right, left, or bilateral lateral pelvic lymph node dissection. And they similarly found that all of the patients, 33 of them who had positive lateral pelvic lymph nodes pathologically, their size cutoff that they found was anyone who had less than a 5 millimeter lymph node after neoadjuvant therapy did not have a positive lymph node. And so that 5 millimeter is an important cutoff to kind of consider when you're evaluating these patients. And so the big question becomes, can dose-escalated neoadjuvant radiotherapy reduce the need for lateral pelvic lymph node dissection? And it's an unanswered question, but I'll show you some data looking at that. And the big divergence is in the eastern part of the world, especially in Japan, They do a lot more dissections in the lateral compartment compared to the Western world. And so this is a study by Chen and colleagues looking at small study again, 53 patients who had chemoradiation followed by TME and adjuvant chemotherapy. Patients who were clinically negative for lateral pelvic lymph nodes received standard 50.4 gray in 28 fractions, and those who had clinical positive lymph nodes had received a sequential boost of radiation up to 59.4 gray. And what they found was that the progression-free survival in both of these groups was equivalent, as well as overall survival. So importantly, there was no lateral compartment surgery in this study, suggesting perhaps that a little bit of boost of radiation can give you a similar outcome compared to extensive surgery. This was a Chinese study looking to evaluate the efficacy of 3 different neoadjuvant treatments. 200 patients, and patients received either neoadjuvant chemotherapy alone versus neoadjuvant chemoradiotherapy, which is a standard long course to 50 gray in 25 fractions, or dose-escalated chemoradiotherapy to up to 58 gray to the positive lymph nodes. And this was all done in 25 treatments. And surgery was TME only in this study as well. And this is looking at the size of the baseline lymph nodes. So it's pretty similar in the boost arm. It was a little bit higher at 9.6 millimeters. However, what's interesting here is that the shrinkage was significantly more, not only in response rate, but also the number of millimeters of shrinkage. Only 3 millimeters with neoadjuvant chemotherapy, 5 with standard course chemoradiation, and 6.5 with high dose chemoradiation, with a response rate of 73%, suggesting a benefit to boosting these lateral lymph nodes. And when they looked at local recurrence, the lowest local recurrence was in the boost arm, compared to chemoradiation or just chemotherapy alone. And again, this was a retrospective study, not randomized. And so both of these actually, and so we have to take them with a grain of salt. No difference in distant metastasis-free survival or cancer-specific survival, which makes sense as well. And interestingly, on this study as well, that 5 millimeter cutoff stood out, and patients that had less than 5 millimeter lateral nodes did significantly better in terms of local regional recurrence, distant metastasis-free survival, as well as cancer-specific survival. And so, is there a consensus in terms of expert consensus for radiation dose escalation? Unfortunately, the data are too sparse to actually form a clear consensus. And so some of the suggested approaches are just stick to the basics. Do standard course neoadjuvant chemoradiation and rely on your surgeons. If the lateral pelvic lymph node has not shrunk, they can take it out with a nodal dissection. Another approach is moderate dose escalation, all done in 25 fractions, and you do standard for the elective nodes in the gross rectal tumor. However, take the lateral pelvic lymph nodes to 55 to 58 gray, depending on dose constraints to the small bowel nearby. A bolder approach is extended dose escalation, where you can take lymph nodes up to 70 gray in the 25 fractions. However, one must be very careful of the bowel, but also importantly the sciatic nerve and the ureter, because that can lead to significant toxicity. So that this should be done very carefully. And so some take-home points here. Hopefully the next edition of the AJCC 9th edition will reflect the fact that patients with lateral pelvic lymph nodes do better than stage 4, and so they should be classified as a subset of stage 3 patients, perhaps. And then important for radiation oncologists is talk to your surgeon. It's really important to know what the plan is. And so that's one of the things that I love about our place is that all of our patients are discussed in a multidisciplinary setting where the surgeon, the radiation oncologist, the medical oncologist, we all discuss the treatment plan. So if surgery is planned, is it only going to be a TME or is a lateral pelvic lymph node dissection also planned? Or is this patient going to undergo watch and wait? And that can change the treatment recommendation from a radiation perspective. And so if the patient is a potential watch and wait candidate, one should give a strong consideration to dose escalation. The last thing you want is the primary tumor gone, but you have a 9 mm lateral pelvic lymph node left. And dealing with that situation is actually very difficult because otherwise the patient would be a watch and wait candidate. And if surgery is planned, long course chemoradiation is very reasonable, or one can consider short course radiation with TME and lateral pelvic lymph node dissection. If there is a desire to omit lateral pelvic lymph node dissection, even if a TME is planned, one should consider dose escalating the lateral nodes, thereby reducing the size of them. And if we can ablate them to less than 5 mm, we can avoid a lateral pelvic lymph node dissection if that's the goal. With that, thank you very much. I'm happy to take questions.
Amazing. So thank you very much for that, Dr. Balagamwala. I got a question for you. So when you're planning this, you talked about a little bit about discussing this at a multidisciplinary tumor board. And so part of the problem is when we have entered this era of watch and wait in terms of and here at Cleveland Clinic, and I'll get into this a little bit in my next presentation, long course chemoradiation followed by systemic chemotherapy. And if the tumor completely goes away and you have a complete clinical response based on imaging, based on endoscopic findings, then they're eligible for watch and wait and avoiding surgery. But you don't know if they're going to respond prior to that, right? They go through the radiation chemo, and then you have to see if they do. And a high rate some studies show up to as much as 40 or 50%. So how do you go about deciding, do I boost this and maybe try to increase their chance of, a complete response and watch and wait? Or if I do that and it doesn't go away, it makes surgery much more treacherous with the extra radiation. How do you go about that decision?
Yeah, no, that's a really important point, and the timing of the surgery matters too. If the surgery is within 4 to 6 weeks of the radiation, then typically it's not as bad with fibrosis. However, if it's later, then it can be a very challenging thing. And I think size can help. If these lymph nodes that are 7, 8, 9 mm, then probably standard long course radiation would be adequate. But for those lymph nodes that are over 10 mm, we really ought to think about at least moderately moderately increasing the dose of the radiation. I'm not convinced that going up to 70 gray would be super wise from a toxicity perspective. I don't personally do that in my practice. I limit it to 55 to 58, but there are other well-known radiation oncologists at MD Anderson, Memorial Sloan Kettering that will do that. But that is, it should be done very carefully with, I would highly suggest MRI guidance when you're delivering the radiation, so that you can delineate the ureter and bowel structures very well, because that can go poorly very quickly.
Great.
Can I also ask a quick question? So in the era of sort of total neoadjuvant therapy, this dose escalation with the radiation to the lateral pelvic nodes, are you going to expect more additional chemotherapy toxicity once you go from that higher dose radiation to the chemotherapy portion of your total neoadjuvant therapy? And can that be a concern as well?
That's a really good point and a good question. I haven't personally seen additional toxicity, especially utilizing intensity modulated radiotherapy or IMRT. We're really able to minimize the dose to small bowel and large bowel really nicely with IMRT. And so my practice has actually evolved to basically 90+% of my patients are treated with IMRT for rectal cancer. I really find that to be beneficial especially from a skin toxicity and a GI toxicity perspective.
Great. And Dr. Gupta, Dr. Liska posed a great question. that I actually had later for our panel, but since he's getting into it now, he's trying to avoid it for himself. So we'll ask you right now. So where does PET CT come into all this in terms of rectal cancer and these lateral nodes? You showed that nice imaging of that giant external iliac node that lit up on PET. Does PET help delineate anything, especially with the restaging following chemoradiation for any nodes that are greater than 5 millimeters? Or do you rely more on the MRI and the characteristics there?
Yeah, overall, I would say as a short answer, probably that we rely heavily on the MRI for looking at a lot of the sort of suspicious imaging criteria associated with positive nodes. The PET we use typically in more of a problem-solving situation. Frankly, in like our first restaging MRI after, let's say, neoadjuvant chemoradiation, we often see that most of the nodes are usually quickly resolved or have decreased significantly in size. The area where we struggle often tends to be the nodes that are probably around the 5 millimeter mark or less. And that's where PET's resolution is also not is not effective in really identifying nodes less than a centimeter. And so that's why the MRI really plays the more important role in identifying those nodes and following them after treatment.
Great. All right, I'm going to get into our next presentation. Keep putting those questions in there. I will not ignore them, and we'll get back to them with our next panel here. So I'm going to go ahead and share my screen. All right, so we have heard about the how you identify them from Dr. Gupta, and how do you figure out these lateral pelvic lymph nodes. We've heard a little bit about the why it matters. Dr. Balghamwala really nicely summarized the data, talking about what it means if you have a lateral pelvic lymph node in terms of your survival, Kaplan-Meier curve, and that really you can, and especially what we know is that if you operate on these patients and get out those lateral pelvic lymph nodes, you can really downstage them from behaving like a stage 4 to a stage 3. So that's why it's really important to monitor these and not ignore these. So with that, I'm going to talk to you a little bit about some surgical considerations, and in addition to some of the data in terms of what drives what we do. So, okay, we talked a little bit about the anatomy, but as a reminder, when we're talking about the lateral pelvic lymph node compartments, we're talking really mostly about the internal iliac nodes and the obturator nodes, which you can see outlined in the diagram here. The reason that these nodes have drainage, get positive, because the distal rectum has lymphatic drainage in 2 different directions. We know it goes into the mesorectum, right, through the superior rectal and inferior mesenteric basin, but it also, through the middle and inferior rectal basin, can go towards the iliac nodes, and that's how it gets into these lateral pelvic compartments. So historically, pelvic recurrence occurred due to failures in technique. But recently, or not so recently, but we've really adopted a total mesorectal excision, which has really standardized the way we do surgery to make sure we get all the mesorectal lymph nodes out, and it's really a decrease in the rectal and inferior mesenteric lymph node basin. So the most common site of local recurrence now is in the lateral pelvic sidewall, and you really have to ask yourself, is that recurrence disease, or is it just untreated disease that had been there all along and just not dealt with? So the incidence, and Dr. Balghamwala talked a little bit about this as well, the incidence varies across the literature based on what you look at, anywhere from 7 to 24%. The Mercury study showed it at 11.7%. We know that the occurrence of positive lateral pelvic lymph nodes is higher, distal lesions and T4 lesions. The presence is definitely a poor prognostic indicator. The Mercury study showed a 42% versus 70% survival rate if they had positive versus negative lateral pelvic lymph nodes. So the philosophy really has been quite different globally. In the eastern part of the world, in Japan, they've really been proponents for a long time of a lateral pelvic lymph node dissection. There, the internal iliac, obturator, external iliac, and even common iliac lymph nodes are all considered regional disease. And as Dr. Balghamwala mentioned, Here, the AJCC only classifies the internal iliac nodes as regional disease, whereas obturator and external iliac as metastatic disease. And so on the Western side of the world, really at the forefront for management of these lateral pelvic lymph nodes has been neoadjuvant therapy, specifically neoadjuvant chemoradiation. So what does that difference show, that difference in philosophy? So the Eastern philosophy, the typical management in the East, in the Far East, is a total mesorectal excision and a prophylactic bilateral pelvic lymph node dissection for all tumors that are at least T3 and below the peritoneal reflection. So the rationale behind this from the Japanese philosophy is really they question the effectiveness of the neoadjuvant therapy on the sidewall nodes. And we don't know exactly, as Dr. Balgobin was mentioning, there's no clear consensus due to dose escalation, how much is being delivered to that lateral compartment. On the rationale, the philosophy in the West is that we really typically rely on neoadjuvant chemoradiation followed by selective lateral pelvic lymph node dissection. So surgically, because of those differences in philosophies, there's a lot less surgery in lateral pelvic lymph nodes done in the Western part of the world, at least historically. So how about the data comparing these two philosophies? So the one randomized controlled trial is the JCOG 0212 study, which looked at mesorectal excision with or without lateral lymph node dissection for clinical stage 2 and 3 lower rectal cancer. So it was a non-inferiority randomized controlled trial with about 700 patients. If the patient was at least a T3 rectal cancer distal to the peritoneal reflection without enlarged lateral pelvic lymph nodes on imaging, and they defined that by greater than or equal to 10 millimeters, then those patients were randomized to a total mesorectal excision versus a total mesorectal excision with a lateral pelvic lymph node dissection. So again, this is patients without evidence of positivity of lateral pelvic lymph nodes on preoperative imaging. The results showed that the TME alone was not inferior. Local recurrence was lower, however, in the total mesorectal excision plus lateral pelvic lymph node dissection, 12.6% versus 7.4%, but that did not reach the criteria for non-inferiority based on their preoperative power calculations, etc. There was no difference noted in 5 or 7 recurrence-free survival. The lateral pelvic lymph node dissection group had a higher blood loss and longer operating times, which kind of intuitively makes sense as you're adding complexity to the operation. There was a subgroup analysis that was done that showed lateral pelvic lymph nodes in the 7 to 10 millimeter range. They had a lower lateral local recurrence-free survival than patients who had a lateral pelvic lymph node smaller than 7 millimeters. So that being said, if you have a lateral pelvic lymph node in that range of 7 to 10, then you have a lower lateral local recurrence-free survival, meaning it's worse off. So the authors concluded from this point that due to a higher recurrence in the patients with lateral pelvic lymph nodes in the 7 to 10 millimeter, these patients may benefit from a combined chemoradiation with TME plus a lateral pelvic lymph node dissection. So, all right, so how do we then compare? Because that was just comparing straight up to surgery with with just a TME alone with a TME plus lateral pelvic lymph node dissection. So how do we compare the Western and Eastern philosophies? Meaning on the Western region, chemoradiotherapy followed by total mesorectal excision alone versus total mesorectal excision plus lateral pelvic lymph node dissection up front, not without omitting radiation. So really all we have are retrospective studies to compare these treatment algorithms. And the crux of it is no study has shown a difference in local recurrence rates. See a couple studies listed here, 5.8 versus 6.9%, 0 versus 14%, a smaller study. But interesting in these studies, the problem is that there's no distinction made between patients with and without enlarged lateral pelvic lymph nodes. And so I think that's a big thing that we're talking about is looking at the MRI, the preoperative MRI, what are the size and the morphologic criteria of these, because that can really help guide you. So how do we define positive lymph nodes? Dr. Gupta talked a little bit about this, but we rely heavily on the MRI. The size criteria, and there's differences in opinion about what's the short axis size criteria that we should look at. If you set 10 millimeters as your short axis size criteria, you're looking at a lateral recurrence rate about 30 to 60%. So I think most people would agree that's pretty darn high. That means that should be a positive lymph node. What about if you drop it to 7 millimeters? What about 5 millimeters? Where do you draw the line in the sand? And the MD Anderson study that Dr. Balgobin also mentioned, if you make it a 5 millimeter cutoff post neoadjuvant treatment after that chemoradiation, that study showed that 64.7% of those patients did have pathologic nodes, almost 2/3, and none of them if you looked that were less than 5 millimeters, had that pathologic node. Things that are important are the shape, the border, the heterogeneity, and the signal intensity. So a couple other studies looking at this, and then we'll get into the surgical anatomy and how we do this operation. So the lateral node consortium is probably the largest study looking at this and looking at about 1,200 patients. They called in large nodes in the short axis that was greater than 7 millimeters, was where they set their criteria for this study. And they looked at chemoradiation plus total mesorectal excision and had about a 20% risk of a lateral local recurrence. So that's when you have preoperatively, you have a node that's greater, at least 7 millimeters in size, and you don't do a lateral pelvic lymph node dissection, 20% of the time you'll get a lateral local recurrence. However, if you add a lateral pelvic lymph node dissection to that, your risk of that lateral recurrence drops from that 19.5% to 5.7%. And about a quarter of the patients you operate on will have positive nodes in that lateral pelvic compartment. So very striking data there. In addition, with this lateral node consortium, they looked at 740 patients that, okay, this time they had that preoperative node, the pretreatment node was at least 7 millimeters, but there was a response on restaging MRI. So they looked at, that was defined as less than 4 millimeters on internal iliac or less than equal to 6 millimeters of the obturator nodes. After 3 years, none of those patients developed local lateral recurrence. Interestingly, in that same group, if they were greater than 7 millimeters originally, but then had an insufficient response, then half those patients did have a lateral recurrence at 5 years. But if you performed a lateral pelvic lymph node dissection, that drops that to 8.7%. Pathologic lymph nodes were present in 74% of that lateral pelvic lymph node dissection group, so quite striking. Akayoshi et al. Had another study, the smaller study, looking at 127 patients. They compared chemoradiation with TME and lateral pelvic lymph node dissection to chemoradiation plus TME alone. Again, their preoperative definition was at least 7 millimeters on the long axis, or if a multidisciplinary tumor board determined it was suspicious, then they went to the lateral pelvic lymph node dissection group. Looking at 38 versus 89 patients, and about 2/3 of the lateral pelvic lymph node dissection group had a positive lymph node dissection. The local recurrence rate was lower, but not statistically significant. The lateral pelvic lymph node patients that, interesting in this study, what they found is that the lateral lymph node dissection group was in a worse expected oncologic group, just because you look at the patients, but what they did is they had a similar local recurrence rate. So your lateral pelvic lymph node dissection, even though the baseline characteristics were worse off, doing that dissection resulted in similar local recurrence rate. Now, this procedure is not to be taken lightly because it can be quite a morbid procedure. It's in a compartment where there's a lot of structures, and systematic reviews have shown that 1 out of 5 patients undergoing these lateral pelvic lymph nodes have a major complication. Vascular structures, nerve structures can cause issues with sexual dysfunction that can be increased with lateral pelvic lymph node dissection, urinary dysfunction, and bowel dysfunction. All these things are major complications and not to be taken lightly. And that's why having a multidisciplinary tumor board like we have here and a discussion for each individual patient, I think, is critical. What's our algorithm here at Cleveland Clinic? We do not perform any prophylactic lateral pelvic lymph node dissection. We have a multidisciplinary tumor board discussion at all stages of treatment. If the initial staging MRI has radiologically suspicious lateral pelvic lymph nodes, then they undergo total neoadjuvant therapy, which at our institution is long course chemoradiation typically, followed by consolidation chemotherapy. We make sure we have interval imaging between each stage, each phase of treatment, that there is a response to that therapy. And then the big question becomes, what happens after neoadjuvant therapy? If the suspicious lymph nodes remain on MRI, based on size, characteristics, morphology, things that we worry about when we review the MRI in our tumor board, then the lateral pelvic lymph node dissection is typically performed of the compartment with those suspicious nodes. If the lymph node disappears, however, then we really individualize the decision. And that's where that discussion is so important to know, okay, patient factors come into play. Are things, even though it might be smaller, is the morphology suspicious? And it's really an individualized decision. So I'm going to show the anatomy here a little bit and talk briefly about the surgery. And then I want to get into some cases and answer the questions with our panel. So when you're done with the dissection, here's kind of the anatomy of how it looks. You start by having your dissection, you retract the ureter immediately, and then you start coming down, preserving your nerves and your ureter, bringing them immediately to try to avoid any injury to those parasympathetic nerves. Then what you're doing is you're skeletonizing this entire compartment. You're starting, your lateral border starts at your external iliac vein. You identify the umbilical artery, which is the first branch off your internal iliac artery, the obturator nerve. The lateral border down over here is the psoas and the obturator muscles. And so here's a screenshot from a video of one of my dissections where you can see this anatomy mirrored from the diagram there. What I'm going to do here is then show a little bit of this video. We don't have a whole lot of time, but I want to give you a little flavor of what this kind of looks like. So here's starting the dissection in this right-sided lateral compartment. You see me starting to get the dissection, pulling that ureter medial. By bringing the ureter medial, we're starting the dissection down in the ureterohypogastric and ureterovesico-hypogastric fascia, which is typically a bloodless plane. And then we can start, that helps define the medial border of our compartment. I'm going to fast forward a little bit, give you a little bit of a flavor here. Here's the dissection. You can see how close we are to that external iliac vein. The red muscle right there is the psoas. The white behind it is the obturator. This dissection is taken right off this external iliac vein, and it can be quite a nerve-wracking portion of the procedure. As you see, it gets pushed on and tugged on a little bit during this operation. But you really have to make sure you completely clear this entire basin. I want to make sure we save time for our panel. So what I will point out is that if you want to see more of that video and others like it and learn how to do this dissection, because this is something that we don't, is often not taught as it's in our training programs, as it's something that is new to the Western side of the world. We are having our 4th annual minimally invasive approaches to rectal cancer symposium coming up in September, which you can register for. We're going to be going over all minimally invasive approaches to rectal cancer, laparoscopic, robotic. We will be going over lateral pelvic lymph node dissection, and there's a live lab that's going to be going on that every participant will have the chance to practice this technique in a cadaver lab. So that's a great experience and a great opportunity if you're interested in. So with that, I'm going to have our panel come off screen. Or come on screen, excuse me, if possible. And we're going to talk about, we'll go through some of these questions, and then we'll do some case presentations. So we'll start with Dr. Karamlu, who had a question. And so Dr. Liska, why don't I start with you? Does the timing of surgery matter? As you know, do you get we know and part of the reason we switched to total neoadjuvant therapy is that we know by waiting longer, more patients have a complete clinical response with that higher waiting period after chemoradiation. Does that trend continue when you look at lateral pelvic lymph nodes? So will we have a higher response rate with a longer wait period after radiation is completed?
No, I think it's a great question. I don't know if we have any data, in terms of are there any differences in the response timing between, the primary tumor, the mesorectal node, or the lateral pelvic nodes. But as Dr. Rosen said, our protocol here, right, we usually start with chemoradiation and then do consolidation chemo. So we then reevaluate them in terms of complete response and surgical plan, quite some time after they completed chemoradiation, right? The consolidation chemotherapy is 4 months. So it's usually, we evaluate them, 5-6 months after they completed chemoradiation. So I think that's definitely a good time point to assess if there's a complete response or not. In majority of cases, the patients that have a complete clinical response at that point, it will be apparent, both in the primary tumor, especially endoscopically on digital exam, and then an MRI for both the mesorectal and the lateral nodes. We definitely have some cases where there's maybe some discordant result where, maybe endoscopically it looks really good, but the MRI maybe sometimes lags behind a little bit, where we can potentially still see, they'll say it's a MR tumor regression grade 3 as opposed to a 1 or 2. And in those cases where we have some discrepancy and we think that, maybe the MRI is just lagging behind, we often do say, let's give it another 6 to 8 weeks, reevaluate with a repeat MRI in patients that are very motivated to have watch and wait. So definitely time matters. But if you don't have, a good sign after the completion of TNT that there likely is a complete response or near complete response, then I don't think waiting much longer makes a difference.
Great. So Dr. Balgamwal, why don't you ask you this next one, since you gave us a lot of the data talking about lateral pelvic lymph nodes and the Kaplan-Meier curve behaving more like stage 3. Did you come across any data showing a study where what percentage of patients with clinically significant lateral pelvic lymph nodes then go on to develop distal metastases, or anything we can extrapolate from the studies that you were telling us about?
I was looking for that actually, and I didn't find any good data showing that people who develop lateral recurrence go on to develop metastatic disease. However, people with larger nodes have been shown, so over 10 millimeters, that is correlated with developing distant metastatic disease.
So one question about ICG, and does ICG make any difference in selecting those patients? I think that I'm guessing I'll handle this one a little bit. I think I'm interpreting this question as, does the ICG help you identify a lateral pelvic lymph node? I would presume maybe injecting intratumorally or peritumorally and then seeing if that would help you identify during the dissection. I've seen some videos of people doing that. I don't routinely use the ICG. I don't like to inject kind of into the tumor or peritumorally, and then in addition, I'm just anatomically clearing out that entire compartment. I think if there was a node maybe in a odd spot or a hard to reach spot, that might be a good time that I would tend to use it. But as long as on the MRI the nodes are within my dissection, the typical dissection compartment, then I personally would not use ICG. I don't know if Dr. Kashino or Dr. Liska, do you guys have any experience using ICG in this or added into your protocol?
I like I've seen some videos where people use it, but if the goal is to clear that entire package of lymph nodes, then I don't really see how it would help that much.
Great. So, Dr. Kahneman, let me ask you this one. Dr. Balgamwala kind of talked to us a little about his philosophy. So it'd be great to hear your practice and if you kind of echo what he does. So he talked a little bit about, a discussion with the surgeon in terms of when to decide to dose escalate those lateral pelvic lymph nodes, do you boost them, et cetera. So one question is asking is, do we routinely boost lateral pelvic lymph nodes when abnormal on imaging as part of our total neoadjuvant therapy? What's your practice?
I have not been boosting these lateral pelvic lymph nodes. So I think in general, I've been doing kind of the standard fractionation, 50.4 and 28 gray. But I do see like these papers online kind of suggesting that there might be a benefit in boosting these nodes. So I was actually speaking to Hassan about it yesterday. But no, I have not personally in my practice been boosting them.
Yeah, I think that's one of the things that, like Hassan mentioned, is such a great part of our practice is discussing individually, right? If it's a patient who is so medically, frail that they're not going to tolerate surgery, I mean, they might not also tolerate the neoadjuvant therapy, but you might think about if it's someone who, for whatever reason, you would not plan for surgery, that's a great patient to then do some dose escalation to try to maybe get some perceived benefit. But it can really, you worry about the interfering with the surgery. Kaz or Dr. Karen, I'll ask you for TNT to use this question is asking you if we do Protege 23 for those cases, or if that's part of our algorithm, or what do you think?
I think there's really no data that selectively elects different types of chemotherapy based on the presence of those lateral lymph nodes. Well, I don't think there's enough data to really differentiate that if you, for example, like in Prodigy 23, where they use modified FOLFIRINOX as opposed to FOLFOX, that results in a better outcome in patients who have lateral positive lymph nodes versus patients that don't. And here in the clinic, we haven't really used a lot of modified FOLFIRINOX in our TNT. And I think one of the issues with the Prodigy 23 was really the control arm, where the control arm was really only standard chemoradiation and really didn't compare modified FOLFIRINOX to a standard TNT arm to see if there was any difference in terms of intensifying your chemotherapy. But certainly the data did show improvement in disease-free survival on local recurrence in the locally advanced or locally advanced rectal cancers. But I don't think there's enough data to really differentiate intensifying your chemotherapy for those patients.
Great. And last question, because we got about 20 minutes left. I want to get through some of these cases. Dr. Gupta, if you had to choose one number that you use on your neoadjuvant therapy size criteria for lateral pelvic lymph nodes, 5, 7, 10, What's your go-to number if I had to pin you down and say all other things being equal, size alone, what would you choose?
I would definitely say greater than 5. Pretty much anything greater than 5, we typically will at least at a minimum report that and consider that, potentially a positive node.
Great.
Yeah.
All right, one more. They snuck in one more question. I'll bite. Dr. Balgamwala, short course radiation at all ever for patients with lateral pelvic lymph nodes, or does it not cover that area? What are your thoughts?
It would cover that area if you do it classically how it's done. However, a lot of our paradigm has transitioned towards watch and wait for patients that actually do have a complete response. And most of the data in the watch and wait world has been long course. And so for those patients, we've been doing long course chemoradiation. The short course followed by chemo is certainly a viable option. However, that typically does involve surgery at the end.
All right, great. I'm going to, let's see, why can't I get out of this? There we go. All right. So I'm going to bring up these case presentations. I'm going to try to stump the stars here. And here we go. All right. So first patient, 61-year-old male, presented with change in bowel habits. He underwent a colonoscopy, and he was found to have an MMR proficient distal rectal adenocarcinoma. On staging imaging, here's some pictures. And Dr. Gupta, it's not fair to throw a few still images up at you and tell you to tell me some things. So I tried to help, tried to be my best radiologist and put some orange arrows, which you guys do for the dumb surgeons, so we can see what you're talking about. But if you can tell us anything you're noticing about some of these pictures, the primary tumor there in the first picture, and then some of the nodes you're seeing throughout the other ones.
Yeah, so certainly, at least looking at that first image you have on the left, it looks like most of the tumor appears to be isolated to the low rectum, and may or may not be involving the sphincter at that level. I mean, there's certainly several large nodes. Certainly, that right external iliac node looks like it's the largest there. That one in the left external iliac distribution, that probably is positive given the irregular margins, and it looks pretty heterogeneous, at least on these images. And it looks like you have another, that last image on the right is showing an enlarged positive right, probably internal iliac distribution node. So certainly, all of these I would consider as positive positive lateral nodes.
All right, great. I agree with your interpretation. Selected the case. Okay, so we've got a distal rectal tumor here. That's an M3. Sorry, excuse me. Wait a minute. Here we go. There we go. Okay, sorry. So yep. So on staging imaging is a T3N2M1. Called M1 because of those external iliac nodes, which are technically here in our AJCC metastatic. So this is a tumor abutting the internal sphincter muscle with perirectal lymph nodes and bilateral lateral pelvic lymph nodes that are seen. CT scans do not show any other evidence of metastatic disease. So I'm going to stop here for a minute and so say, what's our next step and move here? So Dr. Kishinro, what would you recommend now as the next step for this patient with these large pelvic lymph nodes and a locally advanced rectal cancer?
Yeah, so as we just heard, this is kind of the typical patient with high risk of local recurrence, high recurrence of local recurrence. So he has distal rectal cancer and also has enlarged external and internal lymph nodes. So I would recommend, presenting that tumor board, and this is a patient that you want to do TNT on long course chemoradiation, and talk to the radiation oncologist potentially about doing the boost to those really enlarged lateral pelvic nodes.
Yeah, I think, that would be our standard practice. Start with, even though this patient is defined as M1 disease, there's nothing outside that, the posterior external iliac, so it's still technically, treatable and surgically curable. So long course chemoradiation, I agree. And then if there's response, consolidation chemotherapy. The boost, I think you kind of got to think about, do you think it's reasonable you get this patient to surgery or not? And then that's an individualized discussion. Would anyone else disagree with that? Do anything different other than starting with chemoradiation and then chemotherapy? All right, we have an agreement. So let's go back to the presentation. All right, so what this patient actually was treated at an outside hospital. And so at this outside institution, their total neoadjuvant therapy is reversed of ours. They start with induction chemotherapy. This patient got FOLFOX, followed by long course chemoradiation. Following the total neoadjuvant therapy, that's when the patient was then referred over to us for consideration of surgery. And the patient had a repeat flexible sigmoidoscopy that showed a residual mass. There was not a complete endoscopic response. And then a repeat staging imaging, here is what was residual. Dr. Gupta, any thoughts on, this was where that big right-sided external iliac node was. Here you can see it right behind the external iliac there in that first picture, right in here. Yeah. And then over here, something here. Do you want any thoughts on what these look like to you?
Yeah, certainly this is somewhat of what we see often with nodes that are large and post-treatment. This looks to be like something that was probably now centrally necrotic, reflecting the treatment that this patient just went through. It looks like both of these are definitely smaller, and just grossly looking at these two images, it doesn't look like there has been any interval development of any new nodes in those areas. So it's in line with what we would see post-treatment.
All right, great. So here's the read of the MRI. There's a residual posterolateral rectal mass. The left-sided internal iliac nodes that were suspicious before have resolved, and the right-sided external and internal iliac nodes, they had shrunk considerably. Repeat systemic staging did not show with CT chest and pelvis, and a PET CT did not show any disease outside of the pelvis. So now what? So Dr. Kushindra, let's start with you. What are we going to do surgically? Do we say, all right, this was external iliac M1 disease, we're done? The right side that still has, but he still has primary disease of his rectal cancer. He has right-sided residual lateral pelvic lymph node disease. Left side has disappeared. What are you going to recommend for this patient?
I mean, overall, given that over the course of the treatment, this gentleman hadn't developed any evidence of metastatic disease, it's all localized to his pelvis, and he's pretty young. I think doing a surgical resection will be my recommendation. So talking about doing a APR as well as a left. Sorry, which side was gone? The right side was gone.
Right is still positive.
But and doing a selective lateral lymph node dissection, so of the right side.
Okay, Dr. Liska, do you agree?
Yes, I agree. I think that would be kind of the plan that I would go to surgery with. It is possible, because we know that the nodes were positive on the right and the left. I think if everything goes very smoothly during the surgery, I'd definitely start with the right side, but maybe also do the left side, just because this patient kind of has proven that he's very likely to metastasize to these lateral nodes. So yes, the MRI suggests they've responded, but you're already there, you're doing it on one side. And again, if everything goes smoothly, I might just do it on both sides.
Dr. Karamlu, do you have any problems with us surgical hacks taking this out now? Or what do you think?
Obviously the data is controversial, but I think in a young patient like this, that seems very reasonable to do that, especially in the fact that there's been response and there's no evidence of distant metastasis.
All right, so let's see what we did here. So we had the discussion in our tumor board, and it was a similar discussion of what Dr. Liska said, is that technically, and I agree with Dr. Kushindra, only really need to do the right side. This patient was very motivated to have everything done as possible, and if everything was going smoothly, he's opted for us to encourage us to go forward with the disease in the left side. So he did undergo a robotic-assisted abdominal perineal resection with a bilateral pelvic lymph node dissection. The final pathology was YP-T3N1A. There was one of 31 lymph nodes positive, and the lymph node that was positive was that one from the right lateral pelvic lymph node dissection. All right, next case. They're getting younger.
Can I just quickly interrupt with one question? This patient, right, he had the opposite of our protocol in terms of TNT, right? He started with chemotherapy. And I just wonder if and I think Dr. Karamlu has gotten into it a little bit, that we don't really alter our protocol based on these lymph nodes. But I almost wonder, when we do have patients with very extensive, lateral node metastases, are these patients that have more almost systemic disease, right? It is M1 according to the current AJCC staging. And maybe in those patients, it would make sense to start with something systemic first rather than starting with chemoradiation. And that's something that I kind of think about whenever we present these patients, but I haven't heard any consensus about it.
Dr. Liska, I think that's a great point. I think one thing we do know about the sequence is that obviously, I think at the end of the end results of the sequencing really hasn't been clarified and has not made that much of a difference. But I think when you start off with chemoradiation followed by chemotherapy, as opposed to induction chemo followed by chemoradiation, in the former, you tend to get a higher overall pathologic response. So that's why I think we've adopted the chemoradiation followed by chemotherapy because of that higher response.
Right.
Yeah.
Right. No, I agree. Definitely, the Oprah data has been very clear that starting with chemoradiation gets you better pathologic complete response. And I just wonder, there are some patients, right, that are at higher risk for recurring distally, right? Most patients
Correct.
are, and I wonder if these are, and maybe these are the patients that would benefit from attacking sort of systemically first. But I don't know.
To be determined. Maybe a great research trial we could propose to our chair of colorectal surgery to see if it's something they'd be interested in. All right, back to the next case. All right, so the patients are getting younger and younger. So this is a 41-year-old male who presented with a new diagnosis of a distal rectal adenocarcinoma, MMR proficient. Staging imaging. Here's the images. Dr. Gupta, can you tell us what you see in terms of the lateral pelvic lymph nodes there and also the primary tumor there on the right?
Yes, yeah. So on looking at the primary tumor first, that it looks like it's primarily low rectal tumor, also extends to the mid rectum. Looks like the anal canal or anal sphincter is not involved here. Looking at the image on the left, the area you have it looks like it's pointing to like an enlarged node here. The largest one really being this one on the left pelvic sidewall here that's really involving both the internal and obturator distribution, and that is also probably centrally necrotic. So yeah, it looks like a large amount of nodal disease primarily on that left internal / obturator area.
Great. Yep, so the stage imaging showed a rectal mass 5.9 centimeters from the anal verge, right and left-sided lateral pelvic lymphadenopathy. Like you had mentioned, that left side does have some central necrosis. Next steps, I think similar to the last case, what we would do is here at our standard protocol, we do long course chemoradiation followed by consolidation chemotherapy. On repeat staging, the CT scan of the chest and pelvis had a new liver lesion, and the MRI had a residual rectal mass and residual bilateral pelvic lymphadenopathy. So I'll show you here. Is this MRI convincing to you, Dr. Gupta, for this MET?
Yeah, it looks like as far as I could tell, it looks like you have a small lesion here in the right hepatic lobe that has some post-contrast enhancement. That's the image on the right. And then this one on the left looks like it's probably a T2 weighted image here that has some increased T2 signal. Yeah, the only other thing I would look for here is probably a diffusion weighted image just to confirm that there's some restriction there, and otherwise that would be convincing for a MET.
So demanding. You're not happy with the image I provided you. All right, and then here's the MRI, and you can see here the radiologist helped me out with this little white arrow, so I didn't even have to add the orange one. But you see the left-sided node is smaller, still some central necrosis in there in that right one. So, all right, so next steps. Now we've got residual bilateral pelvic lymphadenopathy. We've got a new liver met. So is there any role, Dr. Campbell, is there any role for any more neoadjuvant therapy, any more chemo we should do?
I don't think in this case there's makes more sense to give more chemotherapy. I wouldn't probably do that at this point.
Dr. Canavan, any role for more radiation at this point?
No, I wouldn't.
So it's all on us. Dr. Balgamal, you're a surgeon at heart. You agree we got to go after this now?
I do agree, and I'll just say one thing, kind of coming back to Dr. Liska and Dr. Karamlu's discussion with the previous case, and I think this kind of speaks to it, is patients with large lateral lymph nodes can be at a higher risk for distant metastatic disease. And if you control that with chemo quickly, instead of having that 8 to 9 week delay of doing chemoradiation, that can be really helpful and pay dividends in cases exactly like this one.
All right, so we agreed with our panel, and we took the patient for a combined robotic-assisted low anterior resection with a bilateral pelvic lymph node dissection and an intraoperative laparoscopic liver ultrasound and ablation. There were 3 lesions that were found on biopsy in the liver found to be positive for adenocarcinoma. The pathology came back as YPT3N1B M1A. There were 3 of 21 lymph nodes positive, 1 from the left, and the one in the lateral components that was positive was on the left side, that big necrotic one. All right, last case I'm going to do really quickly. We deserve to have more time on it, but we're almost out of time, so we're going to go through this one quickly. 77-year-old male presents with a new diagnosis of a mid-rectal adenocarcinoma. It was MMR proficient. At the same time, he had a new diagnosis of CLL. Here's his staging imaging. Dr. Gupta, what do you see here?
Yeah, so we, certainly we see several enlarged nodes here. The largest being looking like the one here in the right external iliac area anteriorly. The left image is a post-contrast image. Looks like showing another node in the left external iliac distribution. Differentiating these between a metastatic rectal cancer node versus lymphoma, though sort of the mainstay, generally speaking, they both will look similar in terms of being enlarged. One of the things that helps differentiate lymphoma from other disease processes is that lymphoma typically does not violate vascular planes or cause any narrowing of vascular structure. So in a patient who has a lot of lymphadenopathy or advanced lymphoma, you'll see many large lymph nodes along the vascular distribution that don't actually compress or violate any of those planes. That could be different in the setting of a metastatic node, which would behave differently.
Great. So what I'll say, the staging image was T4A N+ for both mesorectal and that external iliac lymphadenopathy that we saw. Since we only have 2 minutes, I won't torture everybody. There are also some splenomegaly, signs of that CLL, but no other metastatic disease.
Can I ask a quick question?
Please.
In the setting of CLL, would the biopsy of that lymph node, would that be something to consider in this situation?
Yeah. Yes, you're beating me to the punch, but yes, we did biopsy one of those external iliac nodes, which showed CLL. Now we biopsied one. There are multiple, but yes, for the one that was biopsied was CLL. So the patient underwent long course chemoradiation with a plan for TNT, but he didn't tolerate the chemotherapy, had to stop that. And so the repeat imaging showed a response to the tumor, to the treatment, but the persistent primary tumor and the lymphadenopathy was present but decreased by 50%. So now the question is, now what? Would you, Dr. Balghamwala, would you expect CLL lymph nodes to decrease from radiation treatment like that?
It certainly can. Lymphoma is very sensitive to radiation, so if it were CLL, it would definitely decrease. And you would see actually a much bigger response, expect to see a bigger response with CLL than rectal adenocarcinoma.
All right, so we discussed this case. What we did, I'll jump to the punchline here. We discussed it at our tumor board, and there was still some concern based on some of the imaging characteristics that we couldn't be 100% sure that some of those were not CLL, especially some in this right-sided lateral pelvic lymph node compartment. So the patient underwent a robotic low anterior resection with bilateral just sampling of those external iliacs because they were up high anterior on the external iliac, and also a right pelvic lymph node dissection. We found that it was YPT3N1B. 3 of 25 lymph nodes were positive. All of those were mesorectal nodes. And the right-sided lateral pelvic lymph nodes and external iliac lymph nodes were all containing CLL, no metastatic rectal cancer there. The last thing, I'll give one more plug for our minimally invasive approaches to rectal cancer symposium coming up in September. If you're interested, reach on out. We'd love to have you here. It's a great in-person course and cadaver lab. One more question, I'll answer it real quick before we end here. There's a question asking about how many nodes we get on the path report. I've looked this up. When most, I think the average of what you should be hoping for is about 5 to 6 lymph nodes per compartment. But I will say the neoadjuvant therapy and the chemoradiation plus I think waiting longer really decreases the amount of nodes. So it does discourage you a little bit when you get a pathway back. It's only got 3 lymph nodes in it, and you did this giant lateral pelvic node dissection. But I think 4, 5, 6 is kind of where the literature says the average is about. So thanks so much for joining us today. Thank you for our panel for joining. We had a great discussion. Again, that September course, reach on out if you want to join us. Thanks for joining us live from Cleveland Clinic. Reaching out with any questions, and we'll see you next time live from Cleveland Clinic. Take care, everyone.